trained on the way we've always done things, not the way they're supposed to be done.
This is legacy errors.
So dangerous.
Welcome to the Compliant AF podcast, where healthcare compliance isn't just a checklist, it's a competitive advantage.
I'm Amy Woods, CEO of Copperpenny Consulting, a cybersecurity and HIPAA compliance geek who thinks encryption is awesome.
And I'm Kara Kelly, CEO of Clinical HR, fractional HR business partner and HR nerd who is weirdly passionate about employment policy.
If you're a dental or healthcare leader who's tired of check-the-box compliance and wants to actually understand what the rules are and how to build a practice that doesn't live in fear of audits or lawsuits,
you are in the right place. We are digging into the stuff that keeps practice leaders up at night.
We'll break down the boring, call out the BS, and share real strategies with a little snark and a whole lot of caffeine.
This isn't legal advice. We are not your lawyers.
We are two consultants who have seen way too many practices get in trouble because no one explained the rules in a way that actually made sense or made them care.
But since this is a compliance podcast, the content in this podcast or any associated clips is for informational purposes only and does not constitute legal, financial, medical, tax, or regulatory advice. We are not attorneys. Clinical HR LLC and Copperpenny Consulting LLC are not legal firms, and listening to this podcast does not create a client relationship. Always consult a qualified professional advisor for guidance specific to your situation.
So buckle up, because boring compliance just got compliant AF. Welcome back, listeners. Today we are joined by the badass herself, Deanna Otts-Whitfield. And who knew that OSHA and infection control for dentistry could be so cool? So thanks for being here with us, Deanna.
Well, thank you for having me, Amy and Kara. I really appreciate being on the podcast and talking about dirty things.
And that's why we have you here, because we like people that think outside of the box and aren't afraid to say the things that need to be said.
That's right. That's right. There's a lot of things that need to be said, for sure.
Well, let's get into it. What's the Texas phrase, my two Texans?
I mean, Amy's chomping at the bit.
There you go, chomping at the bit.
Okay.
Yeah. Dance with the one that brung you.
There you go. That'll work.
Okay. That'll work. Bless
Okay.
Bless it. No, it's not bless your heart.
Hey,
Okay.
look, you know what? We have some people we say bless your heart to. And for those of you who aren't familiar, that is not a compliment or term of endearment.
In the Midwest, we just say the more punch in the throat approach to it, and it's go F yourself.
Oh, there you go. That's a good one.
Yeah. All right, back to the topic of dirty things, keeping our minds out of the gutter, but back to the top. Deanna, tell us a little bit about what you do. And from the perspective of, we know that you are a OSHA and infection control expert, but tell us the difference between those two and what it is you do to help practices stay compliant with the two different topics here.
Yes. So as clinicians for licensure, we have to have OSHA and infection control standards, right? It's the golden standard that which we practice dentistry in the United States of America. OSHA is there to protect us as employees, as clinicians. The CDC guidelines, the recommendations, infection control, that is the golden umbrella in which we provide dentistry in a safe manner to our patients. So one's a requirement, one's a recommendation. However, let me say that most state dental boards have adopted the CDC recommendations to now make them requirements. So it is in their Dental Practice Act, their rules and regulations, stating that they have to follow the CDC guidelines. So what I like to do is I work with dental offices, individual clinicians, whomever, to help make sure that they are providing the safest visit that they possibly can for their patients, but that they're also protecting themselves when they work, because we as clinicians, we are exposed to all those hazards all day long. That dirty water, those hazardous chemicals, those slips, trips, and falls, all of that nasty stuff we have to deal with every day. And our practices are busy, we're busy, it gets redundant, we do the same stuff all the time, every day. But we have to step back and think about it from a bit larger perspective. Right? We're there to protect ourselves. We're there to protect our patients. We want to provide the best care that we can, but we have to do it in a safe manner.
And OSHA, that's going to be a federal, correct? So that's across the board, every practice in every state, regardless of your head count. Okay. It applies to all the people.
It applies to all the people. And our big main standard that we follow is bloodborne pathogens. But we can't forget the hazard communication standard, the emergency action plan standard. There's radiation things we need to follow. There's ergonomics, workplace violence. There's a whole host of things. We could make a whole podcast just on OSHA.
And when it comes to OSHA and infection control, what makes you the expert at this?
Well, I am a practicing dental hygienist of 16 years, and I went on to get my master's degree in healthcare quality and safety. And I furthered my education when I received my certification in infection control and CD certification in dental infection prevention control from the Association from Dental Safety, formerly known as
Spelled it
OSAP.
out. It keeps me from having to ask.
I know,
Yeah.
I know, CDIPC. So it's the only dental standard certification for infection control. Healthcare has a couple. We have one. So this is our golden ticket for infection control.
Okay, so if somebody were looking at finding a certified provider for OSHA training, there is a dental specific. This is not just OSHA healthcare, because I know from my experience in HR, my experience working with some other professions, that like there's OSHA for construction, for example, which is totally different than what you're going to do. But even in healthcare, there's a more medical OSHA versus a dental OSHA. Is that correct?
Right. Well, we got the bloodborne pathogen standard. That's our holy grail. I'll mention that. It applies to dentistry and healthcare. Now, that thing was written back in 1991. It's old, but it still applies. It still applies. So it applies to us. It applies to healthcare. It applies to long-term, short-term, hospitals, ambulatory centers. It applies to everybody.
So it's all the gross stuff.
It's all the gross stuff. Yes. It's what you do if you have a needle stick injury. It's what you do, if you make sure that you're wearing the proper PPE when you're treating patients. Make sure that the employer is actually providing that PPE. Because once again, OSHA is about, the clinicians. It's about the employees. It's protecting them. So, and then the CDC recommendations are all about protecting the patient primarily, but we've got to follow, regulated guidelines that are evidence-based, scientific, researched guidelines.
And who sets these guidelines?
Well, that would be the Centers for Disease Control and Prevention. They do. Now, unfortunately, we're in the year of our Lord 2025, and the Division for Oral Health was dismantled, unfortunately. We're not going to get into that. So we have what's called the Association for Dental Safety. I mentioned that. That's where I got my certification from. They are fortunately picking up some new guidelines. The last guidelines were updated in 2016. The originals were written in 2003. They're old, okay? They need to be updated. They need to be revamped. The CDC can't do that at this point in time. So the Association for Dental Safety, ADS, is now picking up those recommendations, and they are going to be working on those new guidelines, hopefully to be released in 2026. Crossing our fingers, hopefully. But here's a problem, Kara. We're talking about dirty things. I still see clinicians and practices that are not following guidelines from 2003. They're still not doing the things. Yeah, it's just like HIPAA, right, Amy? They're still not implementing a lot of the things that they're supposed to be doing.
Why do you think that is?
I don't know if it starts, in the schools, if they're not relaying this information, or if it falls on the individual clinicians where they're not taking it upon themselves to learn these new regulations and stay up to date, or if it's the individual practices. So I will say, from my standpoint, being a hygienist, that dentists and assistants, they don't learn a lot of these regulations while they're in school. Hygienists, we do. So it often falls on the hygienists to pick up and make sure that these teams and these offices are doing what they're supposed to be doing. But, once again, we've got to share the wealth. I mean, we've got to make sure we're doing team training and everyone does it together, so you know what your policies are for your individual practice and for yourself as a clinician.
So what are some of the things that you've seen this year, 2025, that are still not being done from the 2016 regulations?
So when I mentioned earlier that some states have not adopted the CDC recommendations as requirements, there's states out there that will say, well, it's only recommended. I don't have the money for that. I don't want to do it. I'm not, whatever. Insert word. One of the big things is offices are not testing their water lines. They may be treating them, they may be shocking them, and I'm talking about the water that's going into patients' mouths that were, during being delivered. But they're not, they may be shocking them, they may be treating them, but they're not testing them. How do they really know that that water coming out of that air water syringe or that high-speed drill is actually safe?
How
I
often are
don't
they
see
supposed to test them?
quarterly, at least quarterly. In fact, the state of Georgia just earlier this year adopted the new requirement that specifically states that offices have to test their water lines once a quarter. And then they have to maintain that documentation for 5 years. That's another big thing. These offices may be doing things, but if it's not documented, it didn't happen. That's the old tale, right? That's, as us as clinicians, when we're writing our notes, if we did something, but we didn't write it down, then it didn't happen. Record keeping is a big deal. And that goes across the board for HIPAA, HR, training, everything. So you can't, that's, I did it. I just didn't write it down. It's not going to fly in court.
And Deanna, we see stories of people getting in trouble for this, for not testing their water. But we also see a lot of horror stories of patients that are affected when offices get Legionnaires or, all that other crud that's in the water lines and they're not testing for it. So that's like putting your dishes in the dishwasher with food still on them and hoping the dishwasher cleans it all. And then you open the dishwasher and it's like, oh, it stinks.
Yes, exactly.
Why? Why does it stink? Because you didn't finish the job. You didn't do the most important part. And I feel like in dentistry, I know it's a weird correlation, but it works.
But you're right. You're absolutely right. Another thing I'm seeing, and it drives me bonkers, is clinicians who don't wash their hands. Don't wash their hands. Now, hand sanitizer is fine when your hands are not dirty. If you don't see dirt or if you don't feel sticky stuff or you didn't touch something that was contaminated, but just washing your hands. When you come back from lunch, wash your hands. Before you see your patient, put your gloves on, wash your hands. If you got to change gloves real quick, you can put some hand sanitizer on, then put new gloves on. But once you're done with that patient, wash your hands. Our gloves are not 100% protective. They're permeable. There's little microscopic holes. And so that patient goop is getting in your hands, underneath your fingernails, those big old Cardi B nails, the coffin nails and all your fancy jewelry. Yeah, you're not supposed to have them. You're not supposed to.
I write enough handbook policies about attire and grooming that talk about the clinical team members' fingernails and that they should be trimmed or filed to a short length.
Yes. In fact, I am working tomorrow in a dental office and I had fingernail polish on my fingers and it was starting to chip. That chipped fingernail polish can harbor millions of bacteria just under that chipped polish. Even if I washed my hands and sanitized, it's still going to be there because it's a layer that holds those microorganisms in there. So I took my fingernail polish off. So I have clean fingers for tomorrow.
Well, and the other thing I get to add to some of these policies now is that it's free of decals, charms, or accessories because apparently we're drilling holes in our nails and adding charms to them. Or we're putting these little 3D flowers on them or the rhinestones. Anything that can glove should not be on your nails.
Well, I've seen people that have pierced the end of their fingernail and put like a hoop in it with a charm. Is that what you mean? Oh my gosh.
Absolutely.
I don't have time for that.
Yeah.
Yeah.
People are special.
We try not to regulate people's appearance, but when it comes to safety, that's different.
So think of it this way. If you have a loved one, if your mom or dad, your brother or sister were in the hospital, they just got out of surgery, they're in recovery, you go and see them, and a nurse walks in and she's got big, long fingernails and she didn't pump that hand sanitizer before she changed the lines on your loved one. Think about that. I mean, really, how many times do you see them go over to that sanitizer pump and sanitize their hands when they're working on a patient? Hopefully a lot. Hopefully a lot. But, in dentistry, we think we're different, but we want to call ourselves healthcare providers. But for whatever reason, it's just dentistry. It's just dentistry. Well, we're not just nothing. You're not going to walk into a hospital and see a big old fluffy couch with big old fluffy pillows and that dinosaur with the human teeth on it. And then 15, pictures of your family and your anniversary and Mother's Day cards. No, it's a sterile environment. Yeah, I mean, I'm not saying don't have any personal effects out there, but be mindful of what's in your operatory. You want to be seen and be called a healthcare professional, we need to start acting like it.
Well, and on the
Right.
topic of gloves and nails and things piercing, what about the gloves that are not being changed between patients? I keep seeing this in some of the Facebook groups, and it just, makes
Mm-hmm.
Gross.
Yeah, it's scary. It's scary. I mean, I don't know where in someone's mind they thought that that is going to be okay. Or they take gloves off and they turn one inside out and it's on one hand so they can reach into a drawer and get a supply, whatever the case is, and they somehow match. I can't even do it. But glo- nothing's cheap, but getting someone sick is very expensive. Change your gloves. I mean, walking around the office and touching things that are clean, your office needs to establish what's clean and what's dirty. If you're going to open the autoclave door, are you opening that with clean hands or dirty gloves? Because if you're putting dirty instruments in there and you close and you lock it and you push the button, were you still wearing dirty gloves? Or did you take them off, sanitize, then shut the door and start the autoclave? Think about it. Because you might be doing it one way, but the person behind you is not doing it that way. And then you're touching dirty stuff. So this is where your office policies come into play. You got to have team training and specific policies for your office.
You say think about it, but as a patient, I really don't want to think too hard about it because it kind of
I
No.
know.
No, my inner germaphobe goes "Bleh," and freaks out and wants to hole up and not be around anybody or get anything cross-contaminated. I mean, my family spent 2 Christmases in a row with pink eye when my older 2 were toddlers, and I did it right the first time, and my husband said, "You were a neurotic mess last time, so maybe let me try it this time." And we got pink eye again. So we do it the way Mom said the first time now.
That's right.
And so when that nasty disease in 2020 hit, we were like, we're going to do it the way Mom says, because Dad is type 1 diabetic and high risk. So I had another thing, Deanna. You were talking another time I was listening to you. You said something about scrubs and how scrubs are not a blanket. And once they're contaminated, it protects the germs, not the people.
Absolutely.
And I heard that and I was like, that is such a profound statement because it allows people to think like, if you've got a blanket on you, it's now contaminated. It's, the same concept as a mask, but, the general public, they're becoming more savvy, especially since the disease we shall not name. And they're more aware of what's happening in healthcare facilities. So would it be fair to assume that the practices that aren't doing things the right way are becoming, I don't know, more analyzed by their patients?
I would say so. Look how smart our patients are becoming. They can find anything on the internet. They see a lot of social media. And if you're an influencer and you're posting things about your office on social media, or you're trying to share a video, wear the proper PPE if you're doing a procedure to make it to at least, even if you're not doing something dirty, just you want to be perceived as doing the right thing. So do the right thing, whether or not you're doing that thing or not. But going back to scrubs are not PPE. Scrubs are not PPE. Scrubs are clothes you put on in the morning.
She rubs her face just to calm herself down.
My eyebrows because they furrow. Scrubs are not PPE. You need to be covering your scrubs. You need to be covering your skin. When your loved one was at the hospital receiving care, was that brain surgeon just doing brain surgery in his scrubs? No, he had a gown. He had a scrub cap on. He had gloves that covered the cuffs on his gown. Your skin cannot be exposed when occupational exposure is likely. So if you're, spit, saliva, blood, tooth particles, fluoride, whatever the case may be, is flying through the air when you're slicing and dicing on this tissue, you need to be covering up your clothes. And PPE is considered appropriate if that material does not soak through onto your clothes. So, that goes for the dentists that wear their street clothes. They cover them up. Your scrubs are not PPE. Cover them up.
So that actually was my next question is what is your recommendation for scrubs being worn in the op versus being worn as street clothes? Because yes, there are doctors that come in their street clothes or they want to do, button down and tie or whatever the case may be with their lab jacket. And that's a choice. Others are wearing scrubs. I have some practices that want their team to change into scrubs once they get to the office and then change back into street clothes if they leave. And then again, like if they go on break, same thing. It doesn't matter if you have them changing into street clothes or out of street clothes into scrubs first thing in the morning. If they leave for lunch and get in their car and go to the fast food place and whatever else and then come back. And so how many practices are really doing that? Should they be doing that? Is there a recommendation for it if they're going to be covering them anyway?
Yes. So it goes back to, once again, scrubs are not PPE. OSHA's bloodborne pathogen standard does state that employers are required to provide some sort of laundry or laundering service for these employees. So whether that's, a washer and dryer in your office, or you take your PPE and you take it to the dry cleaners. If everyone has matching lab jackets with the office name on it, that's perfectly fine. I do see some offices that they come in with their street clothes, maybe sweatpants and a t-shirt. They change into their scrubs for the day. They work with an isolation gown on or a lab jacket on, a scrub cap. They take that PPE off. They go to lunch because their scrubs should be clean and covered, right? That's their work clothes underneath. And then they come back, put their PPE on, finish the day, and then they take their scrubs off and maybe do laundry at the office there. I'm seeing a lot more offices that do have laundry in-house. That's magnificent. That's awesome. That's lovely.
Since the C word, I've been seeing that as well. Because this is something that whenever I do an entire grooming policy and an employee handbook, I ask about their laundry policies. Do they have on-site laundry? If so, who's responsible for it? Should they be putting their scrubs in a certain basket? Making sure that it's not left in the washer overnight. Yes. All of the things that they should be following. But not every practice offers that. So are you saying that the practices that don't offer on-site laundry should be engaging a laundry service? I'm not seeing that with every practice.
If they have reusable PPE, yes, they should have some sort of laundry service that's, that does that for the employee, because it's the employer's responsibility to provide that PPE. If the employer wants that staff member to wear a lab jacket with the office name on it, then that employer must also be able to provide laundry services in-house or out-of-house to that employee.
Okay, but not specifically their scrubs, because their scrubs
not
are
specifically their scrubs, because that's
not like scrub jackets, lab coats.
Scrub jacket, lab coat, scrub caps. Yeah, absolutely. And I love going into offices and they have a full coat rack of all these scrubs, and they just pick one out for the day, a lab jacket for the day, a scrub cap for the day. I love it.
And you bring your own scrub cap with you, right?
I do. So so I temp, and a lot of people are like, well, what do you do with your stuff? Well, I change out of them. I carry a laundry bag with me. Just one I got at the dry cleaners. Just one of those polyester laundry bags. And I change out of all my PPE and my scrubs, and I put them in my laundry basket or my laundry bag, and I take them home. I do my laundry every night, even if I temp every single day, because it's contaminated. I do it by itself in my washer and dryer every night.
Heard opinions on the practices that just hang up everything by size and say, grab a pair that's in your size, because team members are like, I don't really want to do that, especially if they're being laundered in like basic Tide and not anything that's like clinical level detergent.
Right. That's a good question. I don't know. I think there's nothing out there stating that it has to be one way or the other. I would leave that up to the individual teams to decide. And if the staff members are, putting out their opinions about that, then maybe they should have Kara's, Amy's, Deanna's, so on and so forth.
Because I know hospitals will launder like massive amounts of scrubs and they're just going to hand them out by size, but they're also typically using more of an industrial detergent rather than, and granted, they're also dealing with probably more bodily fluid in general than what you are in dentistry. However, still bloodborne pathogen.
It still applies. You're right.
I don't know that I would want to wear somebody else's scrubs that, been going around all day, especially with the PPE that you're wearing and with the thermostat wars that go on, people sweating and armpit grossness that are like in somebody else's scrubs if they weren't using that level of detergent.
That's right.
The thermostat wars only happen because of menopause, right?
You know what?
It's not just the clinical admin fight. It's menopause too.
You know what? I see a lot of offices that have the thermostat lock boxes. In fact, I worked at an office for 10 years in Houston, and they put a lockbox on it because we would turn it up, turn it down, turn it up, turn it down. And they got tired of it. So they locked it, and we didn't have access to change it anymore.
I saw one I saw a reel the other day where it was an exact replica of the thermostat unit, and they had put it over the existing thermostat unit, and it had a battery in it, and it worked, and it looked like it was going up and down, and it would show a temperature in the house. And I really, really thought about getting one for my house because my family keeps turning the temperature up, and I feel like I have steam coming off of me all the time.
That's a pretty genius idea.
Isn't it? But also, that's kind of like the credit card skimmers.
Yeah, true.
That's what they use.
But if you're only skimming your family members, it can't be that bad.
I pay for it one way or another.
There you go.
Everybody's asking what to get their doctor for the holiday season and Boss's Day and things like that. Maybe that's what they should get their doctor.
Thermostat lockbox.
You answered it right there.
It would alleviate stress and drama in the office.
Yes.
Perfect.
That's what we all want.
Oh.
Now, when we were talking before we started recording this session today, you were saying one of the things that you are starting to see more and more is...
Speaking of stress in the office.
Overfilled sharps containers.
This is Deanna's stress in the office, to be clear.
Yes. I temp hygiene, and I go into offices, and I'm constantly asking, where are your sharps containers? I got to switch these out. And I see a lot of offices, they'll have like the hole drilled out in their countertop, and they have like a sharps container attached from underneath. And it may be a short one of those little ones for the operatories, but they're overfilled. Because how often do you look down that hole? So I just, I look at their fire extinguishers, I look at their exit signs, I look at their sharps containers. I start looking at all their enzymes and cleaning products that they use. I look to see if they have a spill kit. I even check their AED to make sure that the batteries are working.
So does every office that brings Deanna into temp get like an impromptu OSHA and infection control?
I don't, but yeah, I guess they kind of do in a way. Or maybe I just bring something to their attention. Maybe they don't have someone checking that stuff on a regular basis. But back to sharps containers. They need to be closed before they are 3/4 full. There is a fill line on the sharps containers.
Why?
Why? Because if you fill it too much, there could be a needle sticking out, and when you shut it, then you could get poked. Because the lid isn't always 100% leak proof per se. The container is itself, but when you close that lid, you never know if you're going to get poked or not. So it needs to be 3/4 full. That's it. Just replace it.
And does that happen on occasion? Like people actually getting poked through the lid?
Yeah, of course. Or, you know what? I always liken it to when families come in for their dental cleanings or dental appointments, and you have kids that are running up and down the hallways in different operatories, sticking your hands in holes, opening up drawers and doors. I'm not a big fan of letting kids run around the office, but that's just me. You never know if some kid's going to stick their hand down in that sharps container hole and stick themselves.
That's fair. And that, I think, was my question. I'm thinking of it from the adult perspective of like, who's actually going to stick themselves? But that's true. That's fair. Kids running around the office trying to play like hide the Hot Wheel or something like that while they're waiting on the parent to get
It's
their...
not just kids. There's some adults that aren't.
Well, we'll just
all
leave
there.
People in general.
Yeah. Not everyone is smart. We'll just say that. And curiosity kills the cat. So I have another question on with sharps containers. When you're disposing of needles or syringes, can you break the tip off before you put it in the... Should you?
Why?
Well, I live with someone who's type 1 diabetic, and he does that sometimes instead of using his sharps container that I bought him to use for this.
So I guess because I'm
waiting for her to go, la, 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 la.
I know. But I always wondered kind of why that was written in there, but it makes sense to me now. You should not bend, break, pull apart, dismantle any kind of sharps. Okay, so just leave it as it is. One hand scoop technique, recap it, dismantle the syringe, the anesthetic carpule, throw it in the sharps container. So I'm even a big fan of recapping it before you dispose of the sharp. I
will play this for him, and you can yell at him too.
Yeah. Well, you give the anesthetic, or you give the injection, whatever the case may be, always recap it. You know, you've got other team members that are cleaning up those rooms. Once again, you've got vendors that are coming into your practice. You've got front desk personnel that may be coming back and presenting treatment plans, whatever the case may be.
IT providers.
Yeah, IT providers.
I had to teach basic infection control and cross-contamination to my IT guys when I had
think
an
that's
IT
great.
company.
I
Yeah.
think that's great.
And we understood, is a room clean or dirty?
Mhm.
And we would always ask, who's the infection control person? Who's my OSHA coordinator back here? And I usually knew who the great offices were because they would follow our guys around and make sure they didn't F up their rooms.
Oh yeah, of
Yeah.
course. Of course. Yeah, for sure.
So that just prompted two questions for me, actually. One, Deanna, you mentioned one-hand scoop technique.
Mhm.
I have had a practice where the team member was not properly picking up sharps and got themselves stuck and had to go and do the testing and workers' comp and all the issues with that.
Right.
Who is responsible in those cases? Is that something where having that training, that ongoing training that was custom to your practice, custom to dentistry, is that going to protect you if a team member does get stuck or cuts himself or whatever the case is? Or is that something that's really on the practice regardless?
Well, I think it's really important to have training no matter what. I mentioned earlier, a lot of states don't license dental assistants. They don't go through formal training. They're trained on the job most of the time. And so being able to teach them on the job the correct ways to handle sharps and needles and so on and so forth really is an important aspect of it all. But if I'm a provider and I am giving an anesthetic injection, I would want to recap that needle myself after I'm done with that procedure so that my staff, my team members, can properly clean up the room in a safe manner. But if, something does happen, and accidents do happen. Accidents happen. I've dismantled the needle from the syringe before and the cap comes off. It happens if you're working too fast. So then if there is a needle stick injury, you must follow your post-exposure protocol that your office should have. You should know where to send that employee, and if there's an infected individual, where they need to get tested.
Okay.
Yeah.
But it needs to be an accident, not negligence, right?
Well, yes, but
not incompetence and idiocy.
Right. But I mean,
how many other adjectives do we have?
But if someone experiences an occupational injury, they must be treated as if it was an accident.
Regardless of whether it's accident or negligence, but
right.
Of like where is the liability?
Right.
And if you've had that training, that generally is going to support the fact that they did exactly know what they're supposed to be doing.
Exactly.
Versus you didn't teach them this.
Exactly.
Though I agree that like if you're the provider, if you're the one that's actually responsible for capping that needle, then that's 100% something you should be doing, because we could just avoid dealing with all of this if we clean properly.
Wouldn't that be nice?
All of this
it would be so nice if everybody did everything they were supposed to do and we weren't necessary.
Was that ounce of prevention's worth a pound of cure?
I need a job though. I need a job.
We will always have a job. We will always have a job. Sadly. I mean, I really do hate that. I really wish that people were better. And, we could sit and point fingers. It's, incomplete education, or it's lack of understanding or caring or budget, or like any of the myriad of things that we could try to blame. But really, it's a combination of all of that, and people are just busy and stuff happens.
It does. It does.
Well, that's why we have workers' comp and liability insurance and
absolutely
all of the things.
And consultants.
All of the things that should be helping to protect your practice. That's the goal, right?
Yeah. Carrie, do you have another question? You said it prompted two questions.
I did. And that's where I was trying to go back and remember what that second question was. I actually had another one from earlier, though, that I wanted to ask. Something that had come up recently was in the sense of infection control and taking care of things properly and disposing of things properly. Hygienists that are taking their tools and throwing them under the counter instead of actually taking them back to theory.
You sent that to
Yeah,
me.
I've seen a post about that recently, and I sent it to you. I was like, oh
Yeah.
no, now I want to go and check like under the cabinets. I
Right?
don't was
Well,
taking care of.
I mean, first of all, why? Why? I don't understand. I don't understand.
Ugh.
And I'm writing a course right now on proper sterilization techniques because it is a very comprehensive multi-step process. And I mean, not only is it unsafe just to throw all your used instruments under the sink and then just wait for it to the end of the day, there is a chemical problem with that because if that blood, that tissue, that debris, that bioburden, the tooth material dries on the end of that instrument, you're going to have to do some sort of mechanical scrubbing. When you do mechanical scrubbing on those instruments, then you're more than likely going to injure yourself. You're not supposed to be doing mechanical scrubbing. And more often than not, when that crud dries on the end of those instruments, you're going to have to use a metal brush, which I see a lot of offices that have. There's something called IFUs, and IFU is called instructions for use. And there are instructions for use for every single instrument and piece of equipment that we have in our office. And metal instruments, stainless steel instruments, are not supposed to be scrubbed with a metal brush. It creates little divots, little scratches in that steel, and then it can't become properly sterilized. So you're just opening the door for a whole lot of problems down the line. And first off, gross. I mean, why? Why? You were trained better. We're trained better. We're better
I
than
don't know if
this.
they don't have enough time to turn the room. I don't know if there's just not a distance there, or if this was a one-off thing. But
Sure.
even if it was, even if it's a one-time thing, no.
Here's an easy solution. If you can't get to your instruments and you can't, whatever, obviously you're cleaning your room. At least I hope you're cleaning your room. Put a little tub of dish soap, just soap and water, and put those instruments in there so they can pre-soak, so that bioburden doesn't dry on the end of those instruments, and so it doesn't make it difficult to remove. There's some ways around that they can fix. I mean, there's a lot of things that they can fix with that.
Still, that's a dirty situation.
I know. Like, come on. You have one job.
Well, and that is cheap and easy. So like in my world, you can change this triangle however you want, but I have a triangle of impossible choices is what I call it.
Mm-hmm.
And on each of the tips, you have a decision. In mine, it's cheap, easy, and secure. It could be cheap, easy, and, not disease filled.
Right.
Not ridden with grossness.
Yeah, for sure. That's yeah.
And you only get two, so you have to pick two.
Mm-hmm.
Which ones do you want?
Yeah.
And you already hit cheap and easy with the dish soap.
Cheap and easy. Yeah, that goes for anything. That goes for all your surgical instruments, your scalers, anything that you're going to reprocess that's not single use. You can sit in that tub of Dawn dish soap and water and just let those instruments soak. In fact, the 2008 sterilization and disinfection guidelines from the CDC state a pre-soak is most often needed for anything. So there you go.
It is in my kitchen too.
I was just about to say that. Don't let my teenagers hear that.
Well, yeah. Well, I mean, think about it.
Pre-soaking all the dishes.
You cook some rice and you leave it dry out on the edge of your pot. Then it's going to be hard to remove, or beans or cheese or whatever the case may be. Run water in it. It's the same thing with your instruments. Keep them moist.
So what do you recommend practices do if we have individuals that are not working up to standard when it comes to infection control?
Go to jail.
No.
Straight to jail. Go to jail.
Do not pass go. Do not collect $200.
Yeah, do not pass go. Do not give them a bonus. No. Every office should have an infection prevention coordinator, a safety coordinator, infection control officer, whatever you want to call it.
And so that, by the way, was my other question. So I'm glad you brought that back up. I'm like, oh, that's what it was. Okay.
And that individual is most often responsible for training in the office and relaying information to the clinicians. So that person should probably approach that individual that's making that mistake. And it should also be brought up to management too.
So how do you have one of those individuals when you've got a practice with like 4 employees in it?
How do you have one of those
Yeah,
individuals?
how do you designate somebody to be this infection control officer whenever you've got a practice with like 4 employees?
Well, usually someone's voluntold. Most often, I see the office, they'll designate maybe the lead dental assistant because they're usually the ones that know the equipment and sterilization that, have a little bit. I don't want to say they have more time because that's not fair to the dental assistants. They're very, very hardworking individuals. But most oftentimes, they're the right hand person of that doctor in the office. And so that doctor can relay that information probably more often to that assistant than they can a hygienist who's probably like on an hour-long recall schedule all day long. And so an assistant can sometimes fit more stuff into their workload, but it's usually, an assistant that's probably a lead assistant. And they oftentimes have a little bit more training. Have more responsibility. They keep all the logs and sterilization, the maintenance manuals, all the things that need to be kept for record keeping in that office. So, if you want to designate yourself, you want to volunteer, or you want to just be that person in your office, there's really no set design as to who that person needs to be, but there needs to be somebody in that office, and preferably a clinician.
Which is a really sad standard, by the way, that there is no set level of education training. There's no certification for this person. They can just say, it's you.
Mm-hmm.
I get it too.
And ideally, all the clinicians we're supposed to have, our infection control and OSHA training once a year, right? So everyone should be trained. It behooves someone to take it upon themselves to do maybe a little extra educational training, that the office perhaps could pay for. If they want to designate someone, maybe the office can come up with something and designate that person and provide them some more comprehensive training along with that responsibility.
100% advocate for that. And here's why. From my HR perspective, I will share kind of dark secrets that we end up having in conversations over the phone. That person can be one of your most dangerous employees. If that person has reported something to you that is not being done properly, and you're not going to take action, and you're not going to get your team trained on how to not do those things, whatever those things may be, that person is always, I swear, it's always the person that threatens to file a complaint. That if you terminate, then they want to go and do a retaliatory complaint, whether it's true or not. If you don't have some kind of record of taking care of whatever they've brought to your attention, and retraining people on the proper way to do that, that person can actually be a challenge whenever it comes to termination, because in some states you'll have whistleblower protections. And so if they have alerted you to this, something that's governed by federal and or state, they may very well fall into that category. And like we've said in our disclaimers, and we always say this, I'm not an attorney, this is not legal advice. Talk to your attorney in your state if you have a concern about this, of course. But it is definitely something that I see on the HR side that makes me say, since we're talking about this and this particular individual, definitely have one. And if there is something that they share with you, I would prioritize getting that infection control at OSHA training, for this very reason.
I absolutely agree. I had a long conversation with the hygienist a couple months ago, and she works in a practice who, for the first time, had a company come in and do some infection control training. Albeit not very good, she was upset that they weren't comprehensive enough. But they came to light that they were not doing a lot of things that they're supposed to be doing. And the doctor became very upset because he thought his lead dental assistant was taking care of all of the things that we're supposed to be doing. Well, come to find out, she was trained by a hygienist or another assistant that was trained by another assistant 15 years ago about things that they did in another state 30 years ago.
Trained on the way we've always done things, not the way they're supposed to be done.
This is legacy errors.
So dangerous.
This is where your office has got to have team training. They got to have team meetings, safety meetings. Talk about things. If you're not going to CE classes as a team and you're doing things individually, because we all do, right? I went to a CE course just for hygienists this past weekend. If I was going to work tomorrow to my team, I would say, hey, this is all that I learned. Let's try and implement these things that we're not doing in our practice because we need to be doing them. But I don't see a lot of offices that are doing that.
No, and sometimes it's the idea of a meeting, which in their minds means no production.
Right.
And
Of course.
nobody really loves meetings. So
Right.
sometimes it's the idea of a meeting or even a training. Like, yes, there's on the clock. It is that type of a curriculum, but position it differently. Maybe this is an internal study club that you're doing
Yeah.
with your clinical team,
Yeah.
that every week or every other week or whatever your cadence is for this, y'all have a certain topic about this. So you're going to say, hey, let's make sure that we're doing this correctly. Let's go find this information and let's make sure everybody here knows how to do this. It breaks that training, for lack of a better term, down into bite-sized chunks, makes it a more proactive approach, and gets the entire team on board with wanting to make sure that this is a priority versus the let's check the box and do it one time for some like prepackaged training. I know Amy has opinions on this.
And I'm over here gagging.
And you know what else you could do as an office? You could put on your website or you can make a little poster. Look, we had 5 team trainings this month of October. Share that with your patients. Tell your
Put it
patients.
on social media.
Yes. Tell them what you're doing, that you're doing things the right way. You know, share with them all the good stuff that you've learned and the things you're implementing into your practice and how you want their visit to be safe and sound. Share that with them.
The number of mission statements and core value statements that say that we are patients first, that we want to give our patients this elevated experience and make this the safest, best treatment that they could possibly receive.
Right.
And you can't do that if you're not going to follow some of these basic standards. And so if you implement this and integrate it into your practice culture, we are going to put our mission first and our values first and make this part of what we do consistently, not just once a year or every other year or whatever we can get away with.
Right.
Or not at all in some cases.
Periodically.
Or not at all in some cases. Yeah,
occasionally.
I agree.
Then that makes that part of it, makes it a lot easier to be able to get your team on board with it because it's just part of what we do here. This is our new tradition.
Right. And the practice owner, the practicing dentist or group of dentists, a lot of it falls back on them. But it goes both ways. You've got to be able to trust your team. You've got to be able to trust the practice owner and the dentists as well. And everyone should have a comprehensive knowledge of what goes on in that office. Yeah.
And I think there's a disconnect in some cases where infection control isn't taught to the admin team in a way that it should be. I mean, Deanna, you and I were talking about this earlier today, where I am a self-professed germaphobe, especially in cold and flu season. I do not want that in my house. I am very busy in third and fourth quarters. I do not need that crap. Literally. I don't need the crud or the crap. Get it both ends. So either way, I don't need it in my house. So when I walk into offices, I never touch their front desk. Most people come in, they lean against the front desk, they put their hands on it, they pull their credit card out, they hand it to the person whose hands are probably not cleaned or sanitized since they went to the bathroom, hopefully. And then they give that card back, and then that's on the counter again. And then that goes in their wallet and goes off with them, and they touch the door. And I'm just imagining if saliva were red, the video on
ADS.
all the everywhere that goes, and I'm just envisioning this and start cringing inside with all of that. And I wonder how many offices actually think about that.
Yeah.
Instead of just general housekeeping, they know they're supposed to keep it clean at all times.
Right.
But do they understand how they're very exposed to the public? They have more people. Every patient that comes in is right in their face, talking to them and doing things and interacting in specific ways. Whereas the clinical team, they're up close and personal. They're literally in their faces, but it's one person at a time.
Right. Absolutely.
So it's just kind of
being cleaned after, presumably being cleaned after every time that one person.
Presumably. Yeah. So let me kind of switch that up for a second. I used to work in an office and we had a couple front desk personnel. After she would come back from lunch, she would go grab a cavi wipe with her bare hands and wipe down her whole station. This goes back to training. She had good ideas to wipe things down, but she did it with her bare hands. She wasn't wearing gloves.
Cavi wipes are not meant for all computer surfaces.
It was toxic. And she just loved it. She just wiped down everything. And so this just goes back to training, folks. But yes, even the front desk personnel, They go to the back sometimes. They may not like to, but they're presenting treatment plans. They may be scheduling something with a patient in the back, whatever the case may be. And you don't want them to not be aware of dirty surfaces, contaminated equipment, touching things. You've been probing all morning and your mouse is dirty, and they come and they start fiddling with your mouse to schedule a patient. And then it's just, they don't know to wash their hands because they don't know that it was dirty.
Well, and
So-
some of the things that I see from front desk team members, administrative team members, are the more obvious, where they're wearing open-toed shoes to the office because they've got to walk through it to get to the doctor's office or whatever your step is.
Right. Exactly. Yeah.
Gross.
It is
Yuck.
gross. Yeah. I don't get
But we like the dirty things.
But we like the dirty things. Yes, we like talking about the dirty things.
And this has been a
to
very
be discussed.
Very dirty conversation. I know we're at the top of our time. Deanna, I know you're going to be a resident featured expert for us here. And so definitely thank you for your time today. Amy, any last questions for Deanna?
What's your favorite thing to fix in an office?
Oh my gosh. My favorite thing to fix in an office.
I know. Oh, the face.
Do you know how many offices they rely solely on hand sanitizer, but it's hard pressed to find soap in some of these places. Hand sanitizer is great, but you have to have soap. You have to have soap. So I will start digging through cabinets, going through supply closet, making sure that they have soap and hand sanitizer and making sure that it's full. I had a doctor the other day kept doing on the hand sanitizer, and so I had to go find new hand sanitizer for him. So that's one of the first things I do. And if it's not out on the counter, if it's underneath the sink cabinet, I make sure to pull it out because I want the patients to see me wash my hands. You are supposed to wash your hands.
Yes,
so
please.
That's one of the first things I do. Is make sure that there's soap and hand sanitizer available. Yes.
We all have our little picadillos.
We do. Yeah.
But I'm glad you're out there trying to keep everyone safe, and not just the practices and the clinicians and the admin team and the teams as a whole, but also the patients, because they don't necessarily have people to advocate for them.
Right.
So, at the end of the day, that's what we're doing this for, is for the patients.
That's right. It's all about keeping y'all safe out there. Because remember, we're patients too.
Well, my last question is, Deanna, how can people reach you if they have any questions, if they want to have you come to their office and train their team properly, how to put the soap out and make sure that they change the sharps containers when they're supposed to, and all of the things. They don't want to do a dirty office. How can they reach you?
Yes. Well, you can find me at copperpennyconsulting.com. All my information's on that. I'm also on Instagram, Deanna RDH, Deanna Otts-Whitfield on Facebook and LinkedIn. And my email is compliance@copperpennyconsulting.com. So I'm a lot of places.
Perfect. Thank you, Deanna.
Thank you, guys.
Thank you guys so much for listening to this episode of Compliant AF. And at the end of the day, just try to keep your practice compliant AF.